Y, sin más, tengo el honor de presentarles a la doctora Teresa Hilgers. La doctora Teresa Hilgers es médico consultora en Naprotecnología y certificada por la American Academy of Fertility Care Professionals. Tiene una estancia complementaria de investigación y especialización médica en el Instituto para la Reproducción Humana San Pablo VI. Es especializada en ginecología, con entrenamiento en laparoscopía y robótica médica, actual presidenta de la Asociación Americana de Cirujanos Especializados en Procreación. Ella es hija del Dr. Thomas Hilgers, creador de la naprotecnología y cofundador del método Creighton. En esta conferencia vamos a contar con traducción simultánea. Bienvenidos.
Good morning. My name is Dr. Teresa Hilgers, and I am very happy to be a part of this program today and excited to talk to you this morning. I am going to provide an introduction into the importance of the CrMS model fertility care system, naprotechnology, and fertility appreciation. These are three terms that you may not have heard before, but they're actually very important, and I hope that you'll gain some understanding and insight into them throughout your. I'm an obstetrician and gynecologist, and I practice medicine at the St. Paul VI Institute in Omaha, Nebraska. When I completed my training in obstetrics and gynecology, I then went on for advanced training in medical and surgical naprotechnology. Once I finished that, I began practicing at the Institute. I'm also trained as a CrMS fertility care practitioner, which means I have been taught how to teach women how to chart their cycles and how to help couples choose days of fertility or infertility to help them achieve or avoid a pregnancy. Depending on what their intention is. And I also currently teach medical students and our fellows in our fellowship program. And I absolutely love teaching. I'm the one on the right. This was her last day on my service during her fellowship year. And so I really enjoy seeing people grow in their field. This is a picture of the St. Paul VI current location. The institute is located in Omaha, Nebraska. Many of you probably do not know where Omaha is state in the United States. It's my absolute. The Institute was founded in 1985 by my parents, Dr. Thomas W. Hilgers and Susan K. Hilgers. They named it after Pope Paul VI, who wrote Humani Vitae. Humani Vitae is an encyclical which was instrumental to the development of the CrMS model and naprotechnology. The Institute is internationally known for its achievements in the field of natural fertility regulation, reproductive medicine, scientific research. We have many educational programs for healthcare professionals and couples. And we have had patients from all over the world come to us for care. If you visited the Institute today, you would see that it is the home to obstetrics and gynecology medical clinic. We see women of all ages, but particularly women of procreative age, women who are between menarche or the start of their periods towards menopause, but we do see women who are postmenopausal as well. We have a laboratory within our institute that is the only laboratory which has identified the reference range for the hormones dependent on the day of the menstrual cycle, as well as the levels of progesterone in pregnancy based off the gestational age of the pregnancy by the gestational weeks. We have an ultrasound center dedicated to the study of ovulation and gynecologic conditions. We have studied more ovulations than anyone else in the world. We have our own fertility care center of Omaha, which is where women and couples go to learn the CrMS model fertility care system. We have an education department, an ethics department, and we have research that occurs within the walls of the Institute. It's very important that we begin our conversation today with a brief description and introduction to the CrMS model fertility care system. Everything we do is based off the CrMS model fertility care system, and so if we talk about other things without understanding this, we will easily get lost. The CrMS model fertility care system is actually a true system of family planning. The woman is taught how to make observations throughout the day and then how to chart the biological markers that she sees in a standardized fashion. These biological markers are also called biomarkers. One of the beautiful things about the CrMS model fertility care system is that the couple can choose if they want to use the system to avoid or achieve a pregnancy. A couple could decide to avoid a pregnancy for 1, 2, 3 months, and then change their mind and decide the next month to achieve a pregnancy. They don't have to stop the method in order to avoid or achieve a pregnancy. They just change how they actually use the system. And so when they are taught how to do this, we can both achieve pregnancy and avoid pregnancy in a very effective manner. For couples who want to avoid pregnancy, the use effectiveness is 96.8%. This is better than hormonal contraceptives, particularly if we look at the birth control pill. Birth control pills are 91% effective at preventing pregnancy. There's also a way in which the CrMS model system can be used to avoid pregnancy 100%. We've actually published how to do this. I won't go into the details regarding this, but I think it's very important to know that a natural system can be used in a way where a couple can effectively avoid pregnancy 100% of the time. But couples can also use the method to achieve pregnancy. It's very important to know that couples with normal fertility should anticipate becoming pregnant quickly if they decide to have intercourse on days of fertility. In the medical world, we are taught that couples' pregnancy rates are only 20% per cycle. That's actually incorrect. When a couple knows when they are fertile or infertile, and then they decide to use days of fertility to achieve pregnancy, if they have normal fertility, 76% of those couples will become pregnant the first cycle they use days of fertility. This means that we can speed up the time to a diagnosis of infertility because we know that by 6 cycles of utilizing days of fertility, most couples should be pregnant. And if they are not, then they have infertility and need to be evaluated. Here we see an example of a CrMS model chart where the couple decided to try for a pregnancy. They utilize achieving related behavior. The period is denoted by the red stamps at the beginning of the cycle. As the follicle grows and produces estrogen, it signals to the cervix to create cervical mucus. This will then tell the woman when she is fertile. The white baby stamps and green baby stamps are a sign of the couple's fertility. This couple utilized days 16 and 18 for intercourse, and they subsequently achieved a pregnancy and had a positive pregnancy test later on. Cervical mucus is very important to the CrMS model system and the couple's fertility. Here we have 4 pictures demonstrating this. Picture A is a microscopic picture of a negative ferning of cervical mucus. There's very poor channel formation, as we can see in picture B. Picture C, however, is a positive fern, and we can see that the cervical mucus has organized itself into a ferning pattern similar to the plant. If we magnify this ferning, we can see in picture D that there are many parallel channels that help facilitate the entry of the sperm into the cervix and uterus. Why is this important? Well, the cervical mucus is very important to the woman's fertility, and it begins a process of creating a biological valve. When the woman is producing mucus of very poor quality, so poor ferning or negative ferning, what we know is that this type of mucus is impenetrable to the sperm, so the sperm cannot enter. As the woman approaches her fertility, the positive ferning mucus starts to increase, and the average channels within that mucus start to increase. This begins about 6 days prior to the peak symptom. And then 4 days after the peak symptom, this channel formation significantly decreases, and we see this creation of a biological valve. This graph here also demonstrates the concept of a biological valve. When the cervical mucus has a low number of channel formation, we see that the sperm does not penetrate. This dashed line, this dashed horizontal line, shows the threshold of when sperm will begin to penetrate the cervical mucus. We can see that as the average channels rise, this is when we reach that threshold. But when there aren't very many channels, then the biological valve closes. So the biological valve is closed here at the beginning. It opens as the average channels increase, and then it decreases again, which effectively closes the biological valve. The post-peak phase is a portion of the woman's cycle when charted that correlates with the luteal phase of the cycle. The luteal phase is a portion of the cycle that occurs after ovulation when the corpus luteum is present, progesterone is produced, and we typically see an absence of cervical mucus. This graph here shows that the post-peak phase is the best clinical estimator of the luteal phase. While the CrMS system can be used to help couples achieve or avoid pregnancy, it is also an amazing tool to monitor a woman's gynecologic health. When my father was first working with his patients who were charting with the CrMS system, he began to notice that women would bring their charts to him when they had difficult conditions such as infertility, recurrent miscarriage, abnormal bleeding, premenstrual syndrome. And when he started to look at their charts with them, he realized that the charts were telling them something they had never seen before. These women had similar abnormal biomarkers, which were consistent from one woman to the next and the type of issue that they were experiencing. And he recognized that the chart could be used to help evaluate, diagnose, and treat the underlying conditions. And this is where Naprotechnology was born. Here we have 4 examples of abnormalities or abnormal biomarkers on the CrMS model chart. The first cycle is a chart that we can see in women with infertility. We see that there is 1 day of mucus present. That is very limited. A normal mucus cycle is 5.6 days in length. These women often suffer from infertility. In the second cycle, we see a very short post-peak phase, which is typically due to a luteal phase abnormality, which often results in low progesterone. Low progesterone puts a woman at risk for miscarriage. If we see this type of charting abnormality, we know that the woman needs to be evaluated by her physician prior to trying to achieve a pregnancy to reduce the risk of miscarriage. In the third cycle, we see significant premenstrual bleeding, which is a sign of low progesterone. When the woman has insufficient progesterone production, The thin blood vessels called capillaries within the endometrium start to break down prematurely, and the sign is the abnormal bleeding. And then in this last cycle, we can see significant abnormal bleeding, which needs to be evaluated. So the biomarkers within the CrMS fertility care system can reveal abnormalities within the woman's menstrual cycle. The standardization of this system of charting allows for trained medical professionals to target the menstrual cycle for evaluation to properly diagnose the disease process and then treat that disease process. This leads us to naprotechnology. One of the difficulties in analyzing the hormones of a woman's menstrual cycle is the dynamic nature of these hormones. They rise and fall throughout the cycle. Some hormones are produced at various points of the cycle, such as progesterone, which is only produced in the luteal phase of the cycle. If we do not have an accurate way of charting the cycles, then we are unable to target and capture these hormonal curves. But we can see with the CrMS system that this is no longer a problem. This woman is charting her cycles with a crate model. We can see that she underwent a hormonal analysis and it was properly targeted. We see a rise of estrogen prior to ovulation. In the luteal phase of the cycle, we then see a second rise of estrogen, that's shown by the black bars, and then a rise of progesterone, shown by the red bars. The cycle is properly targeted, and if there are hormonal abnormalities, we are able to determine what those might be. The CrMS system is a very standardized system. The teaching of the method is standardized. The descriptions of the observations the woman makes is standardized. The recording system is standardized. This standardization allows for objective data to be gathered. We have various biomarkers, for example, that we look at. For example, there's a mucus cycle score, the length of the post-peak phase, and tail and brown bleeding. The standardization also allows for proper timing of diagnostic studies as well as for treatments of certain conditions. In addition, those who are trained medical consultants in understanding the CrMS chart and then applying naprotechnology protocols, they are able to communicate with one medical consultant to another. One of the things I love to do is communicate with my fellow colleagues around the world. And to be honest, I don't speak languages very well. I don't speak English very well. And so in order to communicate, it might seem like a challenge. But when we can look at CrMS charts, it doesn't matter what our language is. We all understand what it is telling us. And we can actually communicate very effectively between medical consultant to medical consultant, practitioner to medical consultant, and couple to medical consultant. It is a universal language, and that is very important to understand. The CrMS fertility care system is the language of naprotechnology. Without it, we do not have naprotechnology. I would now like to spend a few minutes discussing naprotechnology. Naprotechnology stands for Natural Procreative Technology. Naprotechnology is a women's health science that relies on the CrMS fertility care system to evaluate, diagnose, and treat gynecologic conditions in a way that cooperates with the menstrual cycle. The CrMS model is the first system to network family planning with reproductive and gynecologic health monitoring and maintenance. It is very important to understand that naprotechnology is built on good medical science and research. It took years to develop naprotechnology. The foundation and principles of both medical and surgical naprotechnology have been published in the medical literature throughout every decade since the 1970s, and we continue to do research to this day. The term naprotechnology was first introduced in 1991. Prior to this, much reading and understanding the medical literature was performed. Research and development went into the development of the protocols that led to naprotechnology. Since 1991, we have continued to perform research and further development of protocols, surgical techniques, etc. In 2004, the landmark textbook, The Medical and Surgical Practice of Naprotechnology, was published. This textbook refers to over 2,000 references, highlighting how much reading and research and development has occurred with naprotechnology. Naprotechnology has both obstetrical and gynecologic applications. Many forget that naprotechnology can be used during a pregnancy. Perinatal naprotechnology really focuses on creating healthier pregnancies and reducing the rate of preterm labor and delivery. With naprotechnology, we will have preterm labor and delivery rates between 7 and 8%, which is significantly lower than most preterm labor and delivery rates in many countries. Surgical naprotechnology is a very advanced form of gynecologic surgery. It specializes in treating the disease process while protecting the reproductive organs and minimizing the formation of pelvic adhesive disease. Many times, physicians are hesitant to operate on patients because a known side effect of surgery is the creation of pelvic adhesions or scar tissue. Pelvic adhesions are the abnormal connection between two organs. If they negatively impact the reproductive organs, such as the fallopian tubes or the ovaries, the woman could experience infertility. She can also have significant pain from pelvic adhesions. The reduction in pelvic adhesions is very important and one of the major advancements of naprotechnology. We can now perform surgery and reduce the risk of pelvic adhesion formation by 90% when the surgical principles and techniques of naprotechnology are applied. Naprotechnology truly is a medical science where the education of its patients is at its foundation. This is one of my favorite things about naprotechnology. I'm often reminded that doctor is Latin for teacher, and that we are supposed to teach our patients about their bodies, about their medical conditions, and their treatments. I find this education very fulfilling. Naprotechnology educates women in the objective parameters of their menstrual and fertility cycles. Through this education, the woman will develop a partnership with her physician in the evaluation and treatment of the medical condition they have encountered. While the patient needs the medical physician to help them, the physician also needs the woman and her participation with charting. The education is standardized, the standardization makes it objective, and therefore we have reproducible information that the woman can gather, which can be interpreted and used for both medical evaluation and treatment purposes. Naprotechnology has three major cornerstones. These cornerstones are the foundation for naprotechnology, and each are equally important. The CrMS fertility care system is the only charting system which can be used with naprotechnology. Why? Because it's a CrMS fertility care system and its standardized approach that led to the development of naprotechnology. There would be no naprotechnology if the CrMS system did not exist. Good medical science and research is imperative to naprotechnology. We are seeking to push our medical profession forward, and this can only be done with strong research, which leads to a foundational understanding of the science behind the menstrual cycle and the abnormal conditions that negatively impact women's lives. The third cornerstone is the teachings of the Catholic Church. Naprotechnology and those who practice naprotechnology must follow the solid teachings of the Catholic Church regarding human sexuality, particularly the writings of Pope St. Paul VI and Pope St. John Paul II. It is, after all, the encyclical Humanae Vitae, written by Pope St. Paul VI, which led to the creation of the CrMS fertility care system, and is the CrMS fertility care system and good medical science which led to the creation of naprotechnology. If a medical professional seeks to practice naprotechnology, they must adhere to all three cornerstones. If one of these cornerstones is not followed, then it is no longer naprotechnology which they practice. And that is a very important concept to understand. We also need to discuss the current state of women's healthcare. Unfortunately, women's healthcare is not in a very good place right now, and that is due to various reasons which we will discuss. Women's healthcare today has actually a very narrow focus. There are four main things which take up the majority of the research and advancement within women's healthcare today. These areas of focus are abortion, contraception, in vitro fertilization, and sterilization. It seems that women's healthcare is constantly looking about how to make abortion more accessible and better, how to make contraception more accessible, how to make IVF more successful, and how to make sterilization more prevalent. None of these four areas actually solve any of the gynecologic conditions that women suffer from today. Abortion doesn't solve abnormal bleeding, painful periods. It doesn't solve premenstrual symptoms. Contraception doesn't actually treat any of those conditions. It may be manage symptoms, but it doesn't actually treat the condition or remove the condition that is negatively impacting the woman's life. In vitro fertilization skips the evaluation period. Most women who go through IVF actually don't know the cause of their infertility. Infertility is a symptom of an underlying disease process. Typically, when a woman is experiencing infertility, it's the body's sign that her reproductive system is sick and needs help in order to support a healthy pregnancy. Both in vitro fertilization, the evaluation process is typically skipped over. And many times these women are told that they have unexplained infertility. Unexplained infertility is code for they didn't receive an evaluation. And sterilization is being pushed constantly throughout women's health care. But due to this focus, we have actually lost years of research and advancement of women's healthcare due to this. One great example of this is in the world of infertility. Believe it or not, some of our infertility treatments today have lower success rates than what were present in the 1960s. 60 years later, we actually have worse infertility treatments than in the 1960s. That's not advancement. That's actually regression. We will now look at how infertility treatments have worsened over time. Polycystic ovarian disease is a gynecologic condition where the woman has very large ovaries, which creates hormonal chaos within the body. In the 1950s, there was a surgical treatment called an ovarian wedge resection. It is important to note that women with polycystic ovaries often have very long cycles, infrequent ovulations, and high rates of infertility. When women underwent this procedure of an ovarian wedge resection, what they found is they actually had very high rates of regular ovulation and high rates of pregnancy. Their pregnancy rates were actually 66% in 1950. There were two problems with ovarian wedge resection. One, it required surgery. Surgery in the 1950s was a big deal, and there were more complications associated with it. The second issue is that when they performed the ovarian wedge resections, significant adhesion formation occurred. There are many studies that show that women who underwent this procedure had high rates of adhesion formation. Some studies show that 90 to 100% of the women who underwent the procedure developed pelvic adhesions. In the 1960s and 70s, clomiphene citrate, also known as Clomid, came out as a medication. It was advertised as ovulation induction for women with polycystic ovarian disease. They marketed themselves as creating high ovulation rates. But while women ovulated on this medication, their pregnancy rates were actually around 30%. So within 20 years, we went from a 66% pregnancy rate to a 30% pregnancy rate. IVF came out in 1978. Interestingly, that was 10 years after the release of Humanae Vitae. In the 1990s, the success rate for polycystic ovarian disease was around 25% and around 23% in 2001. Unfortunately, our pregnancy rates for polycystic ovarian disease have not improved very much since 2001. At the Institute, my father did a lot of work with polycystic women, and he became frustrated when he realized that the medical treatments such as Clomid were not really helping his polycystic patients. He went back into the medical literature, looked at the wedge resections, and was very impressed by what he saw. He knew that he had to reconfigure the surgery so that he could do it without causing the problems that they had had in the 1950s. Today, we can do ovarian wedge resections and achieve regular ovulation in women who undergo this procedure. In 80 to 90% of women who undergo this procedure, their pregnancy rates are between 60 and 80%, and we can reduce the risk of adhesion formation by 90%. Naprotechnology has taken a good treatment with a couple of problems and has solved those issues that were associated with that treatment. So now we can have a very good treatment for polycystic ovarian disease, and we often remark that an ovarian wedge resection is the closest thing to a cure for polycystic ovarian disease that we have today. A proper evaluation for infertility is very important to understanding the causes of infertility, developing better treatments as well. But you cannot develop better treatments if you do not understand the diagnosis or diagnoses that is causing the infertility. This is a major problem we face with infertility. Many couples are not receiving a proper evaluation. Instead, they are being told that they have unexplained infertility. There are very few couples out there who actually have unexplained infertility. To me, unexplained infertility means we have completely evaluated you, we have treated you, we feel like we have normalized things, and you are still not becoming pregnant. What is the missing piece to the puzzle? If we actually do a proper evaluation, we many times can arrive to the diagnosis. My father has done a lot of work in evaluating infertility during his development of naprotechnology. What he found is that many women have endometriosis. Endometriosis is a condition where cells similar to the lining of the uterus, called the endometrial lining, are displaced outside the uterus. They are actually very inflammatory because they release these molecules called cytokines, which are hostile to the eggs in the ovary, the sperm, and they increase the risk for miscarriage as well. A laparoscopy is a minimally invasive surgery with several small incisions where a camera is placed into the abdomen and the abdomen and pelvis is evaluated for abnormalities. In a study where 250 consecutive patients suffering from infertility underwent laparoscopies, 72.8% of those women had endometriosis. Most interesting is that only 6% of the women who were involved in the study had a normal pelvis. That means 94% of women had some type of abnormality within their pelvis. This is very important to understand. There's another study with over 600 couples, and in that study, endometriosis was present in 77% of these women. Endometriosis is a surgical disease and is surgically treated. It is one of the major causes of infertility. However, it is not properly diagnosed. It is undertreated because it is underevaluated. It is interesting that in the current medical literature, they are starting to recognize that endometriosis does increase the failure rates of IVF. And so some are proposing that the endometriosis be treated prior to the treatment for infertility with IVF. We know that women with endometriosis often have other abnormalities. In fact, infertility is typically multifactorial. And so we not only treat our patients with surgery, but medical management as well. And we can achieve very high pregnancy rates in these group of women. Just like polycystic ovarian disease, we are going to see that the treatment of infertility related to endometriosis has actually worsened over time. Believe it or not, in the 1980s, women had higher pregnancy rates when they had endometriosis and were treated with conservative surgical management. By 36 months after surgery, 53.9% of these women were pregnant. In 2001, with assisted reproductive technology and IVF, 30.8% of women with endometriosis were pregnant or achieved pregnancy. This is a large difference between the two groups of women. But if we were anticipating it, we would have thought that the 2001 rates should be higher than 1981 because we think that we're advancing healthcare. If we are advancing healthcare, our success rates should be improving. They should not be regressing. And so we see time and time again that our treatments are worsening, and it's often due to the fact that we are not looking for the causes of these conditions. And if you do not look for the cause, you cannot develop better treatments for them. This table may be a little difficult to read, but I'm going to explain it to you. This is a report of IV clinics that is submitted every year. This is from 2021, so 20 years after our last slide. This looks at the live births per intended egg retrieval in women who suffer from endometriosis. If we look at this, the pregnancy rates are actually, the live birth rates are actually very low. The singleton births are highlighted in the green row. The success rate is highest in women who are younger than 35 years of age at 38.2%. Between 35 to 37 years of age, women with endometriosis who undergo IVF, 29.3% achieve pregnancy. Between 38 and 40, 19.9%, and it decreases with the age groups. Also of note is the actually very high preterm labor and delivery rate that these women experience. The preterm labor and delivery rate for these patients is around 15%. It does vary slightly from one age group to the next. So even 20 years after that last table, we have seen that we have not made significant strides in the treatment of infertility in women with endometriosis. A common misconception of in vitro fertilization is that it helps everyone with infertility become pregnant, and everyone who goes through IVF does become pregnant. Interestingly, I just read an article that discussed how women who go through IVF overestimate their chances at success. Only 25% of the women who were questioned for this study accurately guessed or estimated what their chances at success were. The majority of women actually overestimated their chances for success. Here we look at a group of women suffering from infertility from the year 2008. In 2008, in the United States, there were 9.5 million women suffering from infertility. That year, there were 148,000 total IVF cycles. 85,000 women went through those cycles. So the reason why the number of women is less is because many times these women have to go through multiple IVF cycles. So if we take 85,576 women and divide it by 9.5 million, we realize that IVF served less than 1% of women with infertility in the United States in the year 2008. There were 46,326 live births. So the percent of women who were successful with IVF, the percent of women where IVF was successful and had a live birth was 0.49% of the total group of women with infertility. Of the 9.5 million women, less than 0.5% of women with infertility are successful with IVF. It actually does not serve a very large group of women. That is very important for us to understand. Many people also do not realize that IVF is actually a very destructive technology. Many embryos or babies are lost in the process of IVF. Here, a calculation was performed to look at how many embryos were lost for every one live birth. Through this calculation, it was determined that approximately 4.2 babies were lost for every one live birth that occurred. In vitro fertilization is a highly abortifacient technology. It does fit with the current state of women's healthcare, which seems to be more of a destructive nature than a supportive nature. We destroy things through in vitro fertilization, sterilization, abortion. It is not a very life-affirming medical practice. I want to present to you a study that was performed at the St. Paul VI Institute. PPVI actually represents Pope Paul VI Institute. Of course, we did not change our name until after Pope Paul VI became canonized. This study was performed in 2018, and it looks at two different groups of women undergoing infertility treatment. There's a group of women who came to the Institute from Grand Island, Nebraska. That's a small town west of Omaha, about 3 hours away. These women came to the Institute first for their medical treatment. They are represented by the blue line. The second group of women represented all the patients who came to the Institute for care. They are in the red line. What we found was that the group from Grand Island had significantly higher pregnancy rates compared to the other group. There are many differences between these two groups of women. The group from Grand Island, Nebraska came to the Institute first. We were their first place for evaluation and treatment. They tended to be younger. They weren't as emotionally drained from their infertility process. They weren't financially drained. They hadn't undergone bad surgeries or bad medical treatments. We are a referral center, and we get many women who come to us to evaluate their infertility. But typically, we are the last people that they come to see. And so the red line represents that. This group of women typically were older, were more financially and emotionally tired, and we found that their success rates were not quite as good. What we learned from the study is that it is very important for women to get appropriate care from a good evaluation that leads to an accurate diagnosis so the proper treatment plan can be instituted. When that occurs, we can have extremely high pregnancy rates. And so we advocate that women get naprotechnology care before anything else. It's very important that these women receive very good care. And this study shows that. When we compare naprotechnology with assisted reproductive technology or ART, we can see that they are actually not similar at all, and they're very different approaches to infertility. With naprotechnology, that's in the column signified by NPT. We see that the diseases are identified in the process of evaluating the infertility. The diseases are also treated. With in vitro fertilization, the diseases are typically not identified, and even if they are, they're not treated. I have had patients tell me before that there was concerns they had endometriosis, but they were told by their IVF doctors not to get it treated, that it wouldn't help them. With Naprotechnology, foundation is laid for future success. What does that mean? That means that many times when we treat these women for their infertility, that their fertility is brought back to life, the roadblocks are removed, and then they do not need help for their second, their third, or their fourth child. I have many patients where I only needed to help them with the first, and then after that, they didn't need my assistance anymore, or my support. Typically, with assisted reproductive technology, those couples always need medical assistance for every single pregnancy. There are some patients that come through our care who will always need help with every pregnancy because of the nature of their infertility. But there's a large percentage of women who will only need our help the first time, and then when their fertility is brought back to life, they're able to conceive on their own without assistance. We typically have a very low multiple pregnancy rate. That means our pregnancies with twins and triplets is quite low. Our percentage is around 3.2%. A major problem with assisted reproductive technology is that there's a huge crisis with storing embryos. Frozen embryos are stored throughout the world, and it creates a large ethical dilemma for parents. What are they supposed to do with their frozen children? With naprotechnology, frozen embryos do not exist. We never create them. We focus on fertility-focused intercourse. With artificial or assisted reproductive technology, the speed to pregnancy might be greater, and the cycle-by-cycle pregnancy could be greater as well. Our per-woman pregnancy rate is higher. Our technology is also built on affirming women's health care, life-affirming women's health care. We do not aim to destroy life. Unfortunately, with IVF and assisted reproductive technology, life is typically destroyed. And naprotechnology is more cost-effective than assisted reproductive technology. As a physician who practices naprotechnology, I am constantly reminded of the good things that come from it. We see healthier women with healthier menstrual cycles, healthier marriages, healthier families, and we see healthier physicians as well. That might be a strange comment to make, but I firmly believe that that is true with naprotechnology. I find so much joy and fulfillment in practicing medicine in this way. When the fruits of your work are good, it is easy to love what you do. But if we were to continue to work in an environment of destruction, such as the current women's healthcare environment, then we would become angry and bitter as physicians. We would resent our patients and what they bring to us. But when we do not take that approach, the physicians themselves are better. I believe that naprotechnology is going to advance women's healthcare. That is through naprotechnology that we will push forward and we will find the causes of the issues that plague women, whether it be infertility or abnormal bleeding or recurrent miscarriage, whatever it might be. When you seek to find the truth, you will find it, and naprotechnology will help us to do that. I hope you enjoy the rest of your day with the program and the presentations ahead of you. Thank you for listening to this presentation, and I hope you learned something from it and that you have gained a new appreciation for the crate model system and naprotechnology.
Thank you so much, Teresa. Now we're going to have a short time for questions and answers. Just a quick reminder for everyone, you can send your questions as you have to the WhatsApp group.
Thank you for having me today.
Okay, so the first question we have for you is, I'm very interested in learning more, and I'd like to incorporate Napro into my practice. So where should I go, or what are the next steps?
Yeah, so in order to incorporate Naprotechnology into your practice, you have to attend a course known as an education phase. Um, you can apply through the St. Paul VI Institute at their website and get more information there. The medical consultants will come to Omaha, Nebraska for their training, and I am one of the teachers who helps with that training.
Thank you so much. We also have been asked how many doctors are currently being prepared to become Napro doctors.
How many doctors? That's a great question. I actually don't know the answer. We have hundreds of doctors from around the world who have gone through the medical consultant course. We have doctors in the United States, of course, Canada, Mexico, Africa, Australia, Asia, everywhere but Antarctica. And in the fellowship group of those doctors who have performed, or completed the advanced training, we have around under 30 doctors in the United States who can do the advanced surgical Naprotechnology.
La doctora Teresa nos comparte que tenemos doctores en preparación realmente en todos los continentes, menos Antártica. Si tenemos doctores participando desde Antártica, este es el momento. Y que en realidad hoy en Estados Unidos hay menos de 30 doctores preparados para enseñar las técnicas quirúrgicas de Naprotechnology. Sobre la primera pregunta, definitivamente vamos a dirigirnos para aprender más directamente al Instituto San Pablo VI y podemos usar el correo que acaba de ser presentado en pantalla para pedir informes. Thank you so much. Teresa, it's been a joy having you with us. You shared that your camera was not working, so I'm just going to explain to everyone. La doctora tuvo un tema con su cámara que falló esta mañana, pero sabemos que hay muchas más preguntas, no pudimos contestarlas todas. Les recordamos que pueden seguirnos en nuestras redes y se seguirán contestando las demás preguntas. It's been really an honor and a joy to have you here with us this morning. You're more than welcome to join in the rest of this day for Jornada Internacional de Naprotecnología, although I know languages are difficult.
Yes. Well, thank you so very much for having me today. I really enjoyed it.
So, as a quick reminder for everyone, right now we're going to have a testimony. The questions that are not being answered on time will be right here, will be answered on our networks at Fertility Care Centers Latin America. And if you have gotten the premium package, you're gonna answer the 3 questions. Todos aquellos que se hayan inscrito al paquete premium para recibir diploma del evento con valor curricular quieren contestar las 3 preguntas que se han dejado en el grupo de WhatsApp y mandarlas al correo contacto@fertilitycare.com. Recuerden que esto permitirá validar su asistencia a cada conferencia. También les recordamos que se requiere validar 9 de las 12 conferencias para poder obtener este diploma. Ahora vamos a escuchar un testimonio.
Hola a todos, somos la familia Landa Salas. Queremos compartir nuestro testimonio acerca del uso de la naprotecnología. En nuestro caso, yo fui diagnosticado en un momento de cáncer, por lo cual fui sometido a sesiones de quimioterapia, lo cual ocasionó que la morfología de mis espermas fueran bajos en cuanto a los niveles que se mostraban. Entonces, luego entendimos que estos niveles solo buscaban lo óptimo para poder realizar una fertilización asistida.
En mi caso también fui diagnosticada con síndrome de ovario poliquístico y fui tratada por la ginecología convencional con anticonceptivos. Eso quiere decir que no pudimos realmente intentar un embarazo de manera natural. Como comenta mi esposo, se nos había dicho que la única manera de lograrlo era de manera asistida. Así que después de este tratamiento nos sometieron a 4 inseminaciones artificiales, que por supuesto fueron todas fallidas, porque nunca se buscó dar una solución a los problemas, sino que solamente se intentaba lograr algo que mi cuerpo no podía mantener. Fue hasta que llegamos a la naprotecnología que entendí que la infertilidad no es una enfermedad, sino un síntoma de que algo no está bien en el cuerpo. La naprotecnología nos ayudó a entender, a diagnosticar, a tener un buen diagnóstico de lo que pasaba en mi cuerpo. Empezaron a identificar, por ejemplo, resistencia a la insulina que no se había identificado antes, a tratarla. Y también en las gráficas se podía ver muy bien que algo no estaba bien con el ciclo del moco. Y fue ahí que los médicos me indicaron que el siguiente paso era una cirugía laparoscópica, porque tenían que ver qué es lo que estaba ocurriendo dentro de mi cuerpo. Esta cirugía me la realizaron en marzo del 2021 y los médicos encontraron que tenía endometriosis cerca del ovario, cosa que no se podía ver con ningún estudio más que con la gráfica que, por el conocimiento que ellos tienen, sospechaban. También tenía endometritis, tenía las trompas semiobstruidas y los quistes, múltiples quistes en los ovarios. Durante la cirugía se removió toda la endometriosis, hubo un drilling ovárico y también se destaparon las trompas. Posterior a la cirugía, estábamos muy contentos de ya tener un diagnóstico completo de lo que ocurría. Lo siguiente fue tratar la endometritis con medicamento y el mes siguiente, para abril del 2021, cuando mi ciclo comenzó, todo fue diferente. Desde el sangrado, el color del sangrado, el moco cervical era tan diferente y ahora era tan elástico, tan transparente, tan lubricante que nunca lo había visto de esa manera. Fue en ese ciclo cuando Dios nos regaló a nuestro hijo. Fue cuando fue una realidad que pudiéramos estar embarazados y damos muchas gracias a Dios por eso. También queremos darles gracias.
Sí, gracias a los doctores y las practitioners que han apoyado a parejas como nosotros a recobrar su salud ginecológica.
Dios les bendiga.
Dios les bendiga.